Good day, everyone. I'm Dr. Dalandag, and I'll be giving you the lecture today on the pancreas. This is a short topic, so please do take time to read your textbooks and prepare for your examinations while you are reading this chapter. As a review of the structure of the pancreas, we have two portions. We have the exocrine, which composes majority of the pancreas, and we also have the endocrine pancreas, which is composed of your islets of Langerhans, endocrine cell clusters, and these are scattered throughout the gland. The exocrine pancreas secrete proenzymes like your trypsinogen, chymotrypsinogen, procarboxypeptidase, proelastase, kallikreinogen, and phospholipase A and B. And these all help in digestion of substances. While the endocrine pancreas are responsible for your insulin, glucagon, somatostatin, and pancreatic polypeptide. And if your exocrine pancreas is approximately 80 to 85% of the organ, your endocrine pancreas is approximately only 1 to 2% of the organ mass. Like any organ in the human body, the pancreas can also be susceptible for congenital anomalies. The first and the most common one would be pancreas divisum. So this is the most common congenital anomaly of the pancreas. In a normal individual, the main pancreatic duct, which is the duct of Wirsung, this one, joins the common bile duct just proximal to the papilla of Vater. So it will join the papilla of Vater. This is the normal structure. While your duct of Santorini, this one, drains into the duodenum through a separate minor papilla. So it will pass through here. However, in an individual who has pancreas divisum, there is failure of fusion of the fetal duct systems of the dorsal and ventral pancreatic primordia. So there will be an atomic variant wherein the bulk of the pancreas drains into the duodenum instead of the papilla of Vater. And the bad thing about this is individuals with pancreas divisum is predisposed to developing chronic pancreatitis in the future. Another type of anomaly is your annular pancreas. It forms a band ring of normal pancreatic tissue that completely encircles the second portion of the duodenum. Let me point it out. So this one is your pancreas, which will completely encircle the second portion of the duodenum. This can produce duodenal obstruction. Another type of anomaly would be your ectopic pancreas. Pancreatic tissue that is aberrantly located or ectopic is found in approximately 2% during careful post-mortem examinations or analysis. So that means the individual died already, and upon careful examination of the entire pancreas or the entire organ system of the body, a pathologist will find an ectopic pancreas. The favored sites of ectopia are your stomach and duodenum, followed by the jejunum, mecal diverticula, and the ileum. Most of the time, these are incidental findings wherein the patient or the dead individual will not have any signs and symptoms which will point to having ectopic pancreas. So this most often than not will not cause any issues while the patient was still alive. Upon microscopic viewing, what we'll find will be normal appearing pancreatic acini, glands, and even islets of Langerhans sometimes. Again, the problem with this is the pancreas is found elsewhere in the body. That's why it's ectopic. It's not found in its normal location. If there will be signs and symptoms caused by this ectopia, it will usually be pain due to localized inflammation, or if irritated, it may incite or cause mucosal bleeding. Another type of anomaly will be agenesis, wherein the pancreas will fail to develop. This is very rare, but it can occur, and this is due to the homozygous germline mutations, which involves the homeobox transcription factor PDX1, which is critical for the development of the pancreas. Pancreatitis. There are two types or two forms of pancreatitis. We have the acute and the chronic, which has their individual characteristic findings or clinical features. Both acute and chronic are initiated by injuries that lead to autodigestion of the pancreas by its own enzymes. The pancreas has a lot of enzymes. We have the zymogens, we have the trypsin, we even have the lipase, which is quite common. Under normal circumstances, there are several factors which protect the pancreas from autodigestion. First is, most digestive enzymes are synthesized as inactive proenzymes or your zymogens, and they are packaged within secretory granules. So they do not come in as active immediately. They are still inactive, and they have to be typically activated by trypsin. Without trypsin, they will remain inactive. Trypsin in itself is activated by duodenal enteropeptidase, or also known as your enterokinase, in the small bowel. As a result, intrapancreatic activation of proenzymes is normally minimal because trypsin is activated in the small bowel. Another protection is that acinar and ductal cells secrete trypsin inhibitors, including serine protease inhibitor, your SPINK1, which further limit your intrapancreatic trypsin activity. So again, there are normal factors which protect us from digesting our own pancreas. Again, as a review, most digestive enzymes present in the pancreas are secreted inactive, or your zymogens, and they are found inside secretory granules. In order for these proenzymes to be activated, they need trypsin. Trypsin is not activated in the pancreas. Instead, it is activated in the small bowel. That's why intrapancreatic activation of proenzymes is very minimal in amount, because again, the one that activates the proenzymes, which is your trypsin, is activated in the small bowel and not in the pancreas itself. Aside from this fact, we have acinar and ductal cells which secrete trypsin inhibitors. So just in case we have an overabundance of trypsin, which makes your proenzymes active, which can cause autodigestion, we have our own trypsin inhibitors found within the pancreas itself. So this will further limit intrapancreatic trypsin activity. Normally, we have all these factors to protect us from auto-digesting our own pancreas. Pancreatitis occurs when these protective mechanisms are disrupted or overwhelmed. First is acute pancreatitis. This is characterized by a reversible pancreatic parenchymal injury and inflammation. Again, this is still reversible. It has many causes, and it includes toxic exposures, primarily alcohol, pancreatic duct obstruction like your biliary calculi or even neoplasms or tumors, inherited genetic defects, vascular injury, and infections as well. Majority of the cases, approximately 80% of the cases, are due to biliary tract disease and alcoholism. Approximately 35 to 60% of cases have gallstone pancreatitis, meaning there is the presence of gallstones causing the obstruction. So there are several etiologic factors in acute pancreatitis. We have the metabolic, we have the genetic, we have the mechanical, we have the vascular, and we have the infectious as well. So for the metabolic, the most common one would be alcoholism. And we also have gallstones in the mechanical. This is found in your textbook, by the way. What causes acute pancreatitis? This results from inappropriate release and activation of pancreatic enzymes that in turn destroy pancreatic tissue and elicit an acute inflammatory reaction. Please don't forget the three factors which protect us from autodigestion of the pancreas. We have the proenzymes which are inactive. We have the trypsin which is responsible for activating the proenzymes. And this trypsin is secreted in the small bowel and not inside the pancreas. And we also have our acinar and ductal cells which secrete trypsin inhibitors. There are three proposed pathways in the pathogenesis of acute pancreatitis. First is duct obstruction. So mostly it will be your biliary sludge and cholelithiasis, but it can also be due to periampullary obstruction. We also have your acinar cell injury, and we also have defective intracellular transport. For the third one, this has not been thoroughly studied in human subjects. This has been studied in animal models, so its relation to the development of human acute pancreatitis is not yet fully understood. We will discuss these three in more detail during the next slides. The first is your pancreatic duct obstruction. Gallstones and biliary sludge, as I mentioned earlier, are the most common causes. Other causes can be your periampullary obstruction. Example would be your pancreatic cancer. Also, choledococcyles. Also, parasites. The most common ones are your Ascaris lumbricoides and your Clonorchis. Pancreas divisum can also cause pancreatic duct obstruction. What happens here is that there will be an increased intrapancreatic duct pressure, and this will lead to the accumulation of enzyme-rich fluid within the interstitium. Not all enzymes in the pancreas are inactive, or also known as proenzymes. There are certain enzymes which are secreted in active form immediately, and an example would be your lipase. This has the potential to cause local fat necrosis. So if there is necrosis already, it will cause the stellate cells and leukocytes to become activated because they sense that there is an ongoing destruction. So what it will do is it will release pro-inflammatory mediators that promote microvascular leak, and the development of interstitial edema as well. So it worsens the condition. It's already obstructed and there is already edema within the pancreatic duct. Because of this edema, it will further compromise the blood flow, and because of this, there will be vascular insufficiency leading to ischemic injury in the long run. If there is no blood flowing, it will cause the death of the tissue involved. The second cause or possible cause of acute pancreatitis would be the primary acinar cell injury. This will lead to the release of digestive enzymes, inflammation, and tissue autodigestion. So it's almost similar with your first cause, which is the duct obstruction. This will result in oxidative stress and the generation of intracellular free radicals. This will lead to membrane lipid oxidation and transcription factor activation. This will induce the expression of chemokines that will attract mononuclear cells. And mononuclear cells also have the capability to release enzymes which can further the injury present already. Another factor that we need to consider, which is an important trigger for trypsin regulation, would be calcium influx. If there is increased calcium influx, it will trigger excessive trypsin activation. If you recall the 2 or 3 slides before this, we mentioned that trypsin regulates the proenzymes from becoming active because they are the ones which activates these inactive enzymes. So if we have a lot of trypsin, that means we will activate a lot of proenzymes, and this can lead to autodigestion of your pancreas as well. The third one is the defective intracellular transport of proenzymes within acinar cells. Pancreatic proenzymes, of which the cathepsin family of hydrolases is most important, are aberrantly delivered to lysosomes. Hydrolases then activate pancreatic proenzymes that disrupt lysosomal membranes, which ultimately lead to the release of activated enzymes. Again, once enzymes are activated, it can lead to oversupply, which can eventually cause the autodigestion of the pancreas. For this specific type of pathway, this has been studied in animal models of a acinar injury. So it is not yet clear if this mechanism is relevant to human development of acute pancreatitis. Two factors have been proposed to cause or contribute to alcohol-induced pancreatitis. We have the duct obstruction and acinar cell damage. Alcohol consumption frequently increases the contraction of the sphincter of Oddi, and chronic alcohol ingestion results in the secretion of protein-rich pancreatic fluid that is prone to form inspissated protein plugs that obstruct small pancreatic ducts. So it can cause pancreatic duct obstruction. This will lead to alcohol-induced oxidative stress that may eventually generate free radicals. There are also other proven or suspected triggers of acute pancreatitis in sporadic cases. So this includes metabolic disorders such as hypertriglyceridemia or your hypertriglyceridemia, and hypercalcemic states such as your hyperparathyroidism. There can be genetic lesions, which will be discussed later, and medications as well. So this can also cause or trigger acute pancreatitis. By the way, GLP-1 agonists, this is quite popular nowadays because this helps individuals, uh, depends on the type, it helps individuals control their blood sugar or make individuals or help individuals lose weight. So these are commonly injected nowadays. However, it's quite difficult to purchase because there is less supply and there is high demand. Other possible causes can be traumatic acinar cell injury. This can be due to blunt abdominal trauma. For example, an individual gets involved in a car accident or got hit, accidentally hit by something uh, blunt like a paddle or boxing, whether intentional or unintentional, or a iatrogenic injury during surgery or endoscopic retrograde cholangiopancreatography. This is unintentional injury. Another one would be ischemic acinar cell injury, which can be due to shock, vascular thrombosis, embolism, or vasculitis. And the last one can be infections such as mumps that can lead to acute pancreatitis through direct acinar cell injury. Hereditary factors are increasingly recognized as causes of pancreatitis as well. Affected individuals have recurrent attacks of severe acute pancreatitis, which often begins in childhood and can ultimately lead to chronic pancreatitis. The feature shared by most forms of hereditary pancreatitis is a defect that increases or sustains the activity of trypsin. Again, the function of trypsin is to activate proenzymes or inactive enzymes in the pancreatic duct. Three genes are implicated in hereditary pancreatitis, and these are your PRSS1, SPINK1, and CFTR. Most hereditary cases are due to gain of function mutations in the trypsinogen gene known as your PRSS1. Some of these PRSS1 gene mutations make trypsin resistant to self-inactivation. So trypsin will get activated over and over. Again, trypsin is important in order for proenzymes to become activated. So these are inherited predisposition to pancreatitis. This table is again found in your textbook. So you have specific genes involved and the functions as well. Please take note which ones inhibit trypsin and which ones are capable of activating trypsin. By the way, among all the genes mentioned earlier, it's your PRSS1 which has a 40% lifetime risk of developing pancreatic cancer. So let's now proceed to the morphology of acute pancreatitis. This can range from limited inflammation and edema to extensive necrosis and hemorrhage. The basic alterations which we can see under the microscope are the following. We have microvascular leak and edema. We have fat necrosis. We have acute inflammation. We have damage of pancreatic parenchyma. And we have blood vessel destruction with interstitial hemorrhage. Kindly focus your attention on the picture on your right. So, hold on. This portion here, this would be your fat necrosis. While your parenchymal autodigestion or necrosis would be this portion here. So we have hemorrhage. So we have bleeding here. And we have acute inflammation as well. What are the clinical features we expect in a patient with acute pancreatitis? Number one, our cardinal manifestation is abdominal pain. This is constant, this is intense, this can be referred to the upper or mid back and even to the left shoulder. Individual can also have anorexia, nausea, and vomiting, which can be common as well. So what do we expect to find when we perform laboratory procedures? During the first 4 to 12 hours after the onset of pain, we expect to see elevated serum amylase and lipase levels. The most specific and sensitive marker of acute pancreatitis would be your serum lipase. Again, if you recall, lipase is an active enzyme immediately upon secretion. This specific enzyme remains elevated for 8 to 14 days after the onset of pain, while your serum amylase, which can also be used, has a short half-life and may return to normal in 3 to 5 days. We can also use imaging studies such as computed tomography scanning, which will help us directly visualize the enlarged and inflamed pancreas, such as the one encircled in yellow in the picture. This is also useful in the diagnosis of pancreatitis. How do we manage or how do we treat pancreatitis? Treatment centers on resting the pancreas by total elimination of oral intake. We do this along with supportive therapy with intravenous fluids and analgesia. Remember that there is an intense pain being felt by the patient. Most individuals with acute pancreatitis recover fully, but about 5% with severe acute pancreatitis die in the first week of illness. The most serious complication, by the way, for acute pancreatitis would be your acute respiratory distress syndrome and acute renal failure. Now let us proceed to chronic pancreatitis. This refers or is defined as the prolonged inflammation of the pancreas associated with irreversible destruction already of the exocrine pancreas or parenchyma, fibrosis, and in the late stages, loss of endocrine parenchyma already. The most common cause of chronic pancreatitis would be long-term alcohol use. What causes chronic pancreatitis? This often follows repeated episodes of acute pancreatitis. Remember that there are individuals who survive acute pancreatitis. They do not die. But unfortunately, if it keeps on coming back, it will eventually become chronic pancreatitis. Acute pancreatitis initiates a sequence of perilobular fibrosis, duct distortion, and altered secretions that, as a result of recurrent injury, will ultimately lead to loss of exocrine parenchyma and fibrosis as well. Chronic pancreatic injury of any cause leads to local production of inflammatory mediators that promote fibrosis and acinar cell loss. This is a diagram of how acute pancreatitis happens. So you can see that there is a acinar cell injury which results in the release of digestive enzymes. So your digestive enzymes will be released, such as your proenzymes and sometimes even lipase. Okay? So once this will be released in the circulation or within the pancreas, this will lead to a cascade of events, including activation of inflammatory mediators, your acute and chronic inflammatory cells, which also ultimately will lead to further destruction because your inflammatory cells also has the capability to release enzymes. And these enzymes can digest or lyse your surrounding tissue as well. It can also lead to vascular injury and edema. So it will compromise blood flow, it will cause obstruction, so on and so forth. In most patients, complete resolution of the acute injury occurs with restoration of your acinar cell mass. So again, majority will get healed. A few may die depending on the severity. Now, this is how we will picture out chronic pancreatitis. There will be repeated episodes of acinar cell injury that will lead to the production of your cytokines, such as your transforming growth factor B and platelet-derived factor, which will result in the production of your uh, myofibroblast proliferation, collagen synthesis, and remodeling as well. So these factors will ultimately help your pancreas to heal. But in the event that it heals, it will result in other injuries as well. Repeated injury leads to irreversible loss of acinar cell mass, fibrosis, thickening, and exocrine or pancreatic insufficiency. Although it can get healed, it will become quote unquote traumatized already, that there will be irreversible loss of your acinar cells and thickening of your pancreatic parenchyma. What is the picture of chronic pancreatitis under the microscope? This will be characterized by parenchymal fibrosis. Pancreas will show large irregular areas of fibrosis. This can affect the periductal area, intralobular, and even interlobular. And this is the major feature which we must see to diagnose chronic pancreatitis. This is absent in acute pancreatitis. There will be reduction in the number and size of the acini. Islets of Langerhans are relatively resistant to chronic pancreatitis in comparison with the acini. So your Langerhans will not be affected, okay? It will be your acini which will be drastically reduced in number and size. There will also be dilation of the pancreatic ducts. Your inter and intralobular ducts are frequently dilated. and their lumen will show protein plug. So there will be obstruction as well. There will be atrophy, hyperplasia, or squamous metaplasia in your duct epithelium. We will have chronic inflammatory infiltrate, so meaning your lymphocytes, your plasma cells, and macrophages will be seen in the fibrotic areas. And this is how it would look like under the microscope. So for letter A, you have extensive fibrosis. Hold on. So you will have this area, there is extensive fibrosis here. There is extensive fibrosis here as well. And you only have residual islets, which you will find right about here. This is a small islet here, and this could be possible islets as well. They become small as well, but what is mostly affected will be the acini. So you have a few islands of your acini left. So these can be your islands of acini and these ones as well. The rest will be your fibrous tissue. For letter B, let's change the color. For letter B, this is higher magnification. What you will see will be your inspissated eosinophilic ductal concretion. This one, you will find that inside the duct. This is a person with alcoholic chronic pancreatitis. Autoimmune pancreatitis has two forms. You have your type 1 and type 2. Your autoimmune pancreatitis is a distinct form of chronic pancreatitis. So how does type 1 and type 2 differ? Type 1 is associated with the presence of immunoglobulin G4, secreting plasma cells in the pancreas, and is one manifestation of systemic IgG-related disease. While your autoimmune pancreatitis type 2, this is characterized by neutrophilic infiltrate within the epithelium and your lumen. Your type 2 is differentiated from type 1 because they do not have your IgG4 secreting plasma cells. So the difference between the two, type 1 has your IgG4 secreting plasma cells, while type 2 lacks this type of plasma cells. Pancreatitis may mimic pancreatic carcinoma, and this type of pancreatitis responds to steroid therapy. So again, for autoimmune pancreatitis type 1, you have swirling or storiform fibrosis. You have phlebitis, and again, it is rich in your IgG4 secreting plasma cells. For type 2, like I mentioned earlier, you will have a lot of neutrophils within the epithelium and lumen of the medium-sized pancreatic duct, and this will not have your IgG4 secreting plasma cells, which is present in type 1. And this is how it would look like under the microscope. So you will have a lot of your inflammatory cells present as well. Look at the size of the duct. It's quite small. What are the clinical features of chronic pancreatitis as a whole? This may follow multiple bouts of acute pancreatitis with repeated attacks of mild to moderately severe abdominal pain or persistent abdominal and back pain. So between the two, between acute pancreatitis and your chronic pancreatitis, the acute is more debilitating, the acute is more painful. For chronic pancreatitis, it may be entirely silent, so meaning there will be no pain until pancreatic insufficiency and diabetes mellitus will develop. What are the complications of chronic pancreatitis? This is usually not an immediate life-threatening condition, but the long-term outlook is poor, with 20 to 25-year mortality rate of 50%. Pancreatic exocrine insufficiency, chronic malabsorption, diabetes mellitus, all can lead to significant morbidity and contribute to mortality. Pancreatic pseudocysts develop in about 10% of the patients. And again, like I mentioned a few slides back, there is a high risk of developing pancreatic cancer, especially if this is associated with your PRSS1 gene mutation. Now let us proceed to the non-neoplastic cysts. First is your congenital cyst. These are unilocular, meaning only one cyst, thin-walled cysts that likely result from anomalous pancreatic duct development, the one pointed by the white arrow. This can be very small or microscopic, or can become as big as 5 centimeters in diameter. The lining epithelium is composed of cuboidal cells, and if the pressure is high, your cuboidal cells can become flattened epithelial cells. Another one would be your pseudocyst, and these are formed when areas of intrapancreatic or peripancreatic hemorrhage or hemorrhagic fat necrosis are walled off by fibrosis and granulation tissue. So these are not real cysts. And this account for 75% of all pancreatic cysts. What makes it a pseudocyst? It does not have an epithelial lining. This is caused by complication of acute and chronic pancreatitis and traumatic injury to the pancreas. This can resolve spontaneously even without treatment. How do they look like? Usually, pseudocysts are solitary. It can range from something as small as 2 cm to as big as 30 cm in diameter. They may be seen within the substance of the pancreas, or more commonly in the lesser omental sac or in the retroperitoneum, between the stomach and transverse colon, or between the stomach and the liver. Under the microscope, they don't have a lining epithelium, but lined only by fibrous tissue and granulation tissue. Granulation tissue is composed of your fibrosis, blood vessels, and your chronic inflammatory cells. And this is how it would look like. This is an example of your pseudocyst. You have your gross, the one on your left. It's a poorly defined cyst with a necrotic brown-black wall, while the one on your right, that is your microscopic view, as you can see, there is no lining epithelium. This is not a true lining epithelium. You don't see cuboidal cells, you don't see squamous cells. Instead, it's lined by fibrin and granulation tissue only. Let us now proceed to true neoplasms. Cystic neoplasms are diverse tumors that range from harmless, benign cysts to lesions that are precursors to invasive, potentially lethal cancers. Only 5% to 15% of all pancreatic cysts are neoplastic. Less than 5% of all pancreatic neoplasms are cystic. Serocystic neoplasms, if diagnosed, are almost always benign, while intraductal papillary mucinous neoplasms and mucinous cystic neoplasms are precancerous. So if it's plainly serocystic, it's almost always benign. But if there is a word mucinous prior to the cystic neoplasm, consider this as precancerous already. Serocystic neoplasms, again, account for 15 to 25% of all cystic neoplasms of the pancreas. So if it's diagnosed as serocystic, it's approximately 15 to 25%. The rest will be that of your mucinous. Serocystic neoplasms are twice more common in women and typically present in 6th to 7th decade of life. This is caused by the inactivation of the VHL tumor suppressor gene on chromosome short arm 3. This is the most common genetic abnormality present in serocystic neoplasms. Usually, you will find this type of neoplasm at the tail of the pancreas, and they present as painless, slow-growing masses. They can be small, approximately 1 to 3 millimeters, can be solitary, or can be multiple, or present as a honeycomb of microcystic lesions, just like the one that you see on the right lower portion. So that is composed of microcystic lesions. These are lined by glycogen-rich cuboidal cells and contain clear, thin, straw-colored fluid. That's why you call that your serocystic neoplasm. Meanwhile, for mucinous cystic neoplasms, 95% arise in women. So a lot of this arise in women. Still, usually arise in the tail of the pancreas, which is similar to your cystic neoplasm. They are painless and they are slow-growing masses. And again, you see the word mucinous. This is considered as a precursor to invasive carcinomas. If for your serocystic, the most common mutation is the one found in your VHL gene, for your mucinous cystic, these are the common genetic abnormalities. You have your oncogenic KRAS mutation, you have your TP53 and SMAD4 mutations, and you also have loss of function mutations of your RNF43. They have larger cystic cavities which are filled with thick tenacious mucin. That's why you call that your mucinous cystic neoplasm. For your serous, it's thin, watery. For your mucinous, it's thick mucin. This is lined by columnar epithelium, like the one that you see again on the right lower picture. You have your simple columnar epithelium and a dense stroma. Your IPMNs, or your intraductal papillary mucinous neoplasms. These involve larger ducts of the pancreas, and this time around, this is more frequently found in men. The first two types of neoplasms, more commonly in women. For your papillary mucinous neoplasms, more common in men. This one usually involves the head of the pancreas. For the first two, tail of the pancreas. For your papillary mucinous, it's usually found in the head of the pancreas. 20% are multifocal. This can progress to invasive cancer. And similar to your mucinous cystic neoplasm, this will have KRAS mutation, loss of function RNF43 mutations, TP53, and SMAD4, plus oncogenic mutation of your GNAS. So your GNAS is responsible for encoding the alpha subunit of the stimulatory G protein. This is not found in other pancreatic cysts. So two features which are useful in distinguishing IPMNS from mucinous cystic neoplasms would be number one, absence of the dense ovarian stroma seen in mucinous cystic neoplasms, and two, there is involvement of the pancreatic duct already. So this is how IPMNS would look like. You can appreciate this one, the finger-like projections, characteristic of your papillary mucinous neoplasms. And the one on the right, that is how it would look like under the microscope. So it will involve the main pancreatic duct, the one on the left, and extends down into the smaller ducts and ductules, the ones on the right. The uncommon solid pseudopapillary neoplasm is found mainly in young women and often presents with abdominal discomfort because of its large size. It has both solid and cystic components, and the neoplastic cells grow in solid sheets as pseudopapillary projections and often appear to be poorly cohesive. The mutated gene in this neoplasm would be your beta-catenin or your CTNNB1 gene. Treatment of choice for this uncommon tumor is resection. Pancreatic carcinoma, also known as your infiltrating ductal adenocarcinoma of the pancreas. Invasive pancreatic cancers arise from non-invasive precursor lesions referred to as your pancreatic intraepithelial neoplasia. So greater than 90% arise from your PIN, while the remainder will arise from cystic lesions such as your mucinous cystic neoplasm and your IPMNS. The genetic and epigenetic alterations identified in PAN-IN are similar to those found in invasive cancers. PAN-IN is often found in pancreatic parenchyma adjacent to infiltrating carcinoma. This is observed while isolated low-grade PAN-IN lesion can be observed in the pancreata of elderly individuals. High-grade PAN-IN, also known as carcinoma in situ, is almost never observed in the absence of an invasive cancer. So high-grade PIN or carcinoma in situ almost always present along with invasive cancer. PAN-IN precedes the development of invasive cancer in genetically engineered mouse models of pancreatic cancer. Isolated case reports have documented individuals with PAN-IN who later develop an invasive pancreatic cancer. This is how it would look like. You have a high-grade PIN or PIN, which involves a small pancreatic duct. You can see here that the columnar epithelium is already pseudostratified and very dark already. This is a model for the progression from normal ducts to your low grade, high grade, and then invasive carcinoma. So you have your low grade PIN. This is found to be due to telomere shortening, which may predispose these lesions to accumulate chromosomal abnormalities and progress to invasive carcinoma. So the first mutation noted here will be the activation of your KRAS genes, and then subsequent inactivation of your CDKN2A. KRAS is the most frequently altered oncogene in pancreatic cancer, and this is found in more than 90% of cases of cancer. CDKN2A is inactivated in 30% of cases through point mutation or homozygous deletion. Once this becomes high grade, your low grade and high grade, they are two distinct different types of neoplasms. High grade, you already have inactivation of three more genes. You have your TP53, you have your SMAD4, and you have your BRCA2 inactivated as well. And then eventually, the high grade will become your full invasive carcinoma. So, in detail, these are the molecular alterations in involved in pancreatic carcinogenesis. The most frequently altered oncogene in pancreatic cancer is the KRAS, with uh, activating point mutations present in greater than 90% of cases. The second one, which is inactivated, would be your CDKN2A, inactivated in 30% of pancreatic cancers. And then in 55%, your SMAD4 will be inactivated, as well as your TP53 in 70 to 75%. So again, most frequently altered will be KRAS. And then you have your CDKN2A, you have your SMAD4, you have uh, your TP53 as well. For the SMAD4, by the way, rarely inactivated in other types of cancer. So when you see SMAD4 inactivated, think of pancreatic adenocarcinoma or pancreatic cancer. So these tables are found in the textbook. Please make sure that you study them. You have your oncogenes, which are inactivated, and you also have your tumor suppressor genes, which are also inactivated. So your oncogenes which are affected will be your KRAS, more than 90%, and then the least frequent will be your BRAF. For your tumor suppressor genes, the most common one will be your TP53, followed by your SMAD4, and then you have your CDKN2A, and then the least common would be your KDM6A. Epidemiology and inheritance. 80% of cases occur after the age of 60. So it may take quite some time before pancreatic cancer develops. Strongest environmental influence will be cigarette smoking. Other risk factors can be chronic pancreatitis, as mentioned earlier, visceral obesity and high body mass index, diabetes mellitus, BRCA2 mutations, most common cause of familial pancreatic cancer, and defects in DNA mismatch repair genes, such as your hereditary non-polyposis colorectal cancer. These are the inherited predisposition to pancreatic cancer. Take note of how high the risk of individuals with Peutz-Jeghers syndrome to have pancreatic cancer by the age of 60, or I'm sorry, by the age of 70. Morphology, location, 60% arise in the head. Try to recall which cystic neoplasm occurs in the head, 15% in the body, and 5% only in the tail. In about 20% of cancers, it diffusely involves the entire pancreas. It will appear grossly as hard, stellate meaning it branches, gray-white, poorly delineated, and firm masses. So it's hard and it's firm. Two features are characteristic: highly invasive, often extends to peripancreatic tissues, and elicits an intense desmoplastic response that results in the deposition of dense collagen. This is what makes the tumor hard and firm because of the intense desmoplastic dense collagen. How does it look like under the microscope? Cancers of the head, body, and tail of the pancreas are indistinguishable. Again, the most commonly affected portion of the pancreas for pancreatic cancer is the head, followed by the body, then the tail. However, if you use this to qualify microscopically, you cannot differentiate the cancers which arise from the head, from the body, or from the tail of the pancreas. They form abortive tubular structures or cell clusters, and they show infiltration. They are very, very infiltrative. Malignant glands are poorly formed and are usually lined by pleomorphic, cuboidal to columnar epithelial cells. Clinical features. Pancreatic cancers usually remain silent until they infiltrate into adjacent features or structures. Usually the first and outstanding symptom will be the pain, which can be excruciating. Obstructive jaundice, if this is associated with carcinoma of the head of the pancreas, can be present, and this is exemplified by the curvature sign. A palpably enlarged, non-tender gallbladder with mild painless jaundice. In the advanced stage, symptoms include weight loss, anorexia, and generalized malaise and weakness. That's why it's too late already for a patient once diagnosed with pancreatic cancer, because that means the disease has progressed already, as evidenced by the symptoms related to the disease. Patients can also have Trousseau syndrome or sign, which is your migratory thrombophlebitis. This is characterized by spontaneously appearing and disappearing migratory thrombosis, found in approximately 10% of patients. So take note of this sign, attributable to the production of platelet aggregating factors and procoagulants from the carcinoma or its necrotic products. What do we expect to find in the laboratory? Non-specific markers such as your carcinoembryonic antigen or your CEA and CA19-9 antigen can be present. Again, these are non-specific markers and lack the sensitivity, meaning these markers can be found in other diseases as well, and this is not uh, primarily found in pancreatic cancer only. However, although it's not used to diagnose, you can use this in follow-up of a patient's response to treatment. For imaging techniques, we can perform endoscopic ultrasonography and CT. They are useful for diagnosis, but you cannot depend on them as screening tests. Prognosis, the course is brief and progressive. Another type of malignancy of the pancreas would be your acinal cell carcinomas, Like normal acinar cells, this type of carcinomas form zymogen granules and produce exocrine enzymes such as trypsin and lipase. 15% develop the syndrome of metastatic fat necrosis due to lipase release into the circulation. They will show loss of function mutations of the APC tumor suppressor gene, as well as your CT, NBB, NNB1 activating point mutation. So this is a bigger picture of your acinar cell carcinoma of the pancreas. There are monomorphic nuclei with prominent nucleoli. So almost the same sizes of your nucleus. And also the color of the cytoplasm, which is pinkish because of the zymogen material. The last tumor, and rare at it, is your pancreatoblastoma. Occur primarily in children 1 to 15 years of age, malignant, but fortunately survival is better compared to your pancreatic ductal adenocarcinoma. This consists of a mixture of squamous cells along with acinar cells. And the mutation is the same with that of your acinar cell carcinoma. You have your APC tumor suppressor gene or your CTNNB1 genes which are affected. So this is how your acinar cell carcinoma will look like. And the one on your right would be your pancreatoblastoma, composed of whorls of epithelioid cells, the ones pointed by the black arrow. That's it for the pancreas. I hope you learned something today. Again, please do read your textbooks. I have to omit a lot of notes, a lot of information due to time constraints. Please do not depend on this recording, and again, read your textbooks. Thank you and God bless everyone.